Thank you so much, Alicia. And it is such a pleasure to be back with you all. Yes, the last time we had this conversation was about a year ago, and I wish I could come to you today with exciting news or good news as far as progress we're making as a country around the substance use epidemic. Unfortunately, we all know that that's not the case, that COVID has exacerbated many of the challenges that people with addiction in our community face. And in fact, for the first time since the CDC has started collecting data around drug overdoses, which is decades old, we surpassed 100,000 overdoses in a 12-month period. So clearly there is still so much work to be done in this space. I think it's fair to say that the healthcare community at large has been somewhat distracted in the last couple of years with COVID. And as we hopefully enter more of this endemic phase of COVID, we can start to shift our attention back towards substance use, which forever I described as the public health crisis of our generation. Of course, COVID sort of put that into the shadows for a bit, but again, this is a massive public health crisis. This is impacting our communities, it's impacting our families and our friends and our neighbors. And there's a lot that we can do in hospitals, as we talked about last time, to help people with substance use disorder around prevention and treatment and harm reduction. And just to very quickly give you maybe a quick refresher from the last time that we met, this is a work of passion of mine in the last several years. I'm a physician assistant by clinical training. I've worked in hospital medicine for about a decade, and I was that provider who was, taking the quote, treat 'em and street 'em, unquote, approach to helping, so-called helping people with addiction. I was that person who stigmatized people with substance use disorder. And through a quality improvement initiative around readmissions and learning about buprenorphine and methadone and peer recovery specialists and all of the failed policies that we've had as a healthcare community and a broader community in the US, I recognize that stigma and that bias, and I've worked really hard to change that and have been a part of a number of initiatives around the country and in Texas and now in Colorado around improving care for hospitalized people with addiction. And my big takeaway from all the various things I've had the privilege of doing in working with people with substance use disorder, I've come to the realization that the single biggest barrier that we have as a healthcare community and as a country in improving care for substance use disorder is stigma, right? Of course, there's policy, of course, there's education, of course, there's reimbursement things and all these other sorts of things that we can put into that bucket. But all of those barriers, education and reimbursement, these are all created by people. And it's the stigma and bias that those people have that drives these policy decisions, that drives these educational decisions, that drives our clinical decisions. And so if we can start to chip away at stigma, if we can start to normalize addiction, just like we do around diabetes and heart failure and so many other diagnoses, we can really, really start to make an impact on this very, very, very important public health crisis. So today we're going to have a really good conversation about this. I'm so excited to be joined by my fellow panelists here. And we're going to touch on many different areas of stigma. We'll talk a little bit about the clinical aspects. We'll talk about things that you can do to improve stigma within your hospitals and within your communities. I'm hoping we'll at least touch on the intersections of the criminal justice system and structural racism and how that has affected our ability to provide care for people with addiction. We'll talk about things that, not in my backyard and some of the stigma that we face in hospitals in providing this care and not necessarily thinking that hospitals are an appropriate place. And so without further ado, let's kick it over to the panel. Enough hearing from me. I do want to encourage everybody, as was mentioned earlier, if you have questions for the panel, if you have questions, put those in the chat box or in the Q&A box, and we will do our best to socialize your questions during the live chat today. But also use the chat box as a way to communicate with your fellow attendees, talk about your own experience, talk about the work that you're doing in your institutions. Let's try and make this as collaborative as possible. So the first question we're going to get to today is, what is one thing your organization has done to concretely address stigma of substance use disorder within the organization? And William, we'll start with you.
So there's two Williams. There's William Stuglik and William Ellis. I think you're asking William Ellis, right?
I am asking William Ellis. Yes, thank you.
Hi, I'm William Ellis, and I'm here at the Howard University Hospital. And one of the things that we have done here is we have incorporated the peer support team, which along with educating the patients, we educate the nurses too. We have a good working relationship with the ER doctors here in the emergency room, and also other doctors throughout the hospital, OR, SICU, and throughout the whole hospital. And what we do is we don't just talk to a patient and educate them, but we make it known to the nurses, what we're looking at and what this person is going through, and how they're just supporting this the next patient. And through educating them what addiction really is. So that's one of the things that we're doing here.
Thanks, William. Absolutely. That lived experience is so important to bring into the hospital. Couldn't agree more. Dreama, how about from your perspective?
So my name is Dreama, and I'm with the Psychiatric Institute of Washington. And just to reiterate what William Ellis said, one of the things that the PIW did was implement the peer program, and not just educating our patients, but we have the great, we're able to educate the nurses and administrators and the other staff on, the different things that patients are dealing with, and show, what outcome can happen. Another thing that we have implemented at PIW with the administrative staff has been really great about is we are starting a Stigma Awareness Day each month to coincide with different things like Opioid Awareness Day, and that is to help educate the staff on unconscious stigmas that they may have. Another thing that PIW has done is with the increase of, we've seen an increase of the LGBTQAI plus community coming into our hospital. And so we've become very, educating people on being very culturally sensitive to them, and, showing how to ask politely, what is your preferred name, and making sure that that's passed on from staff member to staff member so that we don't offend the patients. So there's a lot of things that PIW has definitely implemented since the beginning of the program.
Thanks, Dreama. Can you expand a little bit on the Stigma Awareness Day? That's such a great idea to really help boil up and bring to the surface some of these issues.
So one thing that we're going to do is pick, say, 5 words that are typically used and that are considered stigma words, like relapse, and instead of saying relapse, saying recurrence, and just showing people like why saying different things, what they mean to that person, and even to patients, why certain words are harmful and what helpful words are. And instead of trying to group it all into one, we're just going to pick maybe 5 words and say, this is why this word is harmful, and helping to continue with that. And, maybe having like contests with the nurses and the psych techs to, see how they would change, their conversation with the patient and such.
A great idea. Words matter, right? Dr. Crozo?
Yeah, thank you so much. Good morning. So I'm a philosopher bioethicist. I work in the Lynch Center for Ethics, effectively for MedStar Washington Hospital Center. The Department of Bioethics engages in both policy and education, and largely a very robust consultative service for the hospital. So for those of you who don't or may not be familiar with how clinical bioethics functions in systems like ours. So the bioethics department was approached by Behavioral Health Services, which is distinct from the Department of Psychiatry. Psychiatry clearly is a department that we work very closely with as bioethicists, but this is the larger, broadly construed behavioral health service department. And they contacted us in relation to their hospital-based peer support system program. This program is an extension of the Screening, Brief Intervention, and Referral to Treatment program, also known as SBIRT, which after its inception, at least for MedStar in 2016, within just 2 years, was responsible for around 3,500 referrals for SUD treatment in just 4 of our Maryland hospitals. So before it even reached DC or the hospital center, and we have about 9 hospitals in Maryland. And this was via universal screenings of patients admitted to the emergency department. So if such a screening were to indicate a moderate to high risk concern for substance abuse in an individual, a peer recovery coach, as I take very much similar role to be to 2 of my co-panelists today, they use sort of motivational interviewing techniques. The techniques and their specificity I'm not familiar with, my co-panelists likely are, and offer additional evaluation and referral service for those patients, persons that are considered high risk for SUD. So the question from behavioral health was whether it was ethically supportable or justifiable to conduct similar screenings for persons admitted to the inpatient psych unit, as opposed to the application of some metric or a set of evaluative criteria, or even just clinical judgment, which themselves may be either designed or employed in a way that incorporates unintentional or implicit biases toward particular patient presentations. So my advice was what you might call casuistic, and its casuistry is relevant to forwarding these kinds of concerns. That is, the ethical justification of a decision or process by reference to the justification of a previous decision or process that now stands as a paradigmatic example. So universal screening for patients admitted to inpatient psychiatry not only was ethically justified in terms of considerations for the removal of underlying biases in metrics and in clinical judgment, but it was derivatively justified by the prior and successful use of this process in the emergency department under the SBIRT protocol. So now, in order for any kind of casuistic analysis to be valid, in other words, for us to forward that reasoning to a situation that we're dealing with at hand, the situation involving the decision at hand needs to map on in relevant ways to the previous situation from which you're forwarding your reasoning. In this case, both contexts, both clinical contexts, the emergency department and the inpatient psych unit, in different ways, present the problem of not knowing what substances, if any, are contributing to the medical, to include psychiatric, condition being evaluated, given these contexts less than ideal settings for appropriate initial communication with the patient. Right? It's very difficult sometimes when patients first present to an ED to have those initial conversations, depending on the severity of their presentation. It's very difficult at times to have those initial conversations with patients being admitted to the inpatient unit, especially on FD12s, depending on the severity of the behavioral concern. I should also mention that one of my colleagues also provided another example within our hospital from which this reasoning could be forwarded, and that was the advice we gave to the Department of Obstetrics regarding not just the ethical permissibility, but a normative argument for the universal SUD screening of expectant mothers in order to reduce the opportunity for bias in their department.
Thank you. Very comprehensive, and I think you highlighted so effectively the interesting intersections between ethics and addiction care. And I think it's important to highlight, and this may be a subsequent question later on in the session, is when we think about some of the core principles of delivering clinical care, I've always thought about patient autonomy and how patient autonomy is or is not preserved in the addiction care world, depending on the situation. And I think hospitalization is a very good example where we may blur those lines a little bit ethically sometimes. And so let's revisit that in a couple minutes maybe. Dr. Stuglik, from your perspective, what are one thing that your organization has done in reducing stigma?
Well, good morning, and I think I'm kind of wrapping up a lot of what has been said. I am a chief medical officer here at United Medical Center here in Southeast DC. Most of my career has been as an ER physician. So I was kind of like the treat 'em and street 'em type of clinician that you described before. What we put in place both at Howard and United Medical Center, and I work in both places, is opioid and substance abuse screening as a routine, as part of triage. So when people present to the emergency department for whatever reason they're presenting for, they are asked certain questions that try to determine whether this is an issue for them. It might not be the primary reason that they're coming to the emergency department for or to the hospital for, but from their perspective, but it could be a contributing factor. So the routine screening it's not based on age, it's not based on race, it's not based on the way that you're dressed or the neighborhood that you come from. And it's not like a subjective perception of the person who's doing the triage. It's just everyone is screened. And affirmative answers to those questions essentially triggers what I kind of call as a consult from the peer recovery coaches. So the peer recovery coaches are in place. They're like specialists. They are consultants that are ready to treat patients from the perspective of substance abuse. So just making it routine, part of the triage, from my perspective, takes away a lot of that stigma that people and the bias that people are using and thinking that this is the person that I should ask this question about, or based on certain things. So that's what we put in place, both at Howard and United Medical Center.
Excellent, really strong work. This work isn't easy. I think we can all appreciate. We are talking about a unfortunately highly stigmatized patient population in an environment that's obviously just very political these days, right? And very opinionated. And so it can be hard to make progress in the regard of reducing stigma. And so I'm curious to what extent you faced challenges in doing some of the work that you just described. And if you could offer advice to participants on how to overcome similar challenges in the work that I think they're all aspiring to do. So Dreama, how about from your perspective?
I think one of the biggest challenges is that stigma is it can be so unconsciously deep-seated that to change a person's mind about what drug addiction and substance use disorder really is, and what a person can become, and where they can go, and what relapse is, that's really hard to change in the mind of people because for a lot of reasons, music, movies, television, crime rates rising, and a lot of that has to do with mental health disorder and substance use disorder. So to go to somebody who already has a deep-seated idea of what addiction is and what substance use disorder is, and try to tell them that it can get better, or to take that away is that's probably one of the biggest challenges. And at PIW, the staff, just the overwhelming welcoming of the peer recovery coaches and how open they are to being educated and opening their minds has been an amazing thing. So if we could just take that worldwide, and then it would be, it would be even greater. But that's probably the biggest challenge, I believe.
Absolutely. Dr. Stuglik?
You know, with the biggest, I guess the biggest challenge and the biggest chore was to make sure we put in policies and procedures in place to institutionalize the care, and then also prioritizing the treatment. You know, elevating the treatment to the point where we do have the peer coaches in place. That it is one of the primary things that we do. Interesting from an emergency perspective, oftentimes when I would look at a patient, prepare to go see a patient, oftentimes the peer recovery coach was there before I got there. And so I would come, and at times I would yield to them and say, okay, this is actually more important than my discussion with the patient about abdominal pain, because ultimately they're here for abdominal pain because of the primary issue, which is substance abuse. And so just having that in mind, that patients come and they enter into the healthcare system but for different reasons, whether it's abdominal pain, trauma, even infectious diseases, those are secondary problems to the primary problem, which is a substance abuse problem. So just prioritizing, elevating the care, elevating the status of the peer recovery coaches as true consultants in the healthcare system was not necessarily a challenge, but something that had to be put in place.
Thanks for that. And I just want to elevate the work of Dr. Honora Englander, who's an addiction medicine researcher and physician at OHSU in Oregon. Her and her team have done extensive work looking at peer recovery specialists in the hospital. What are the benefits of it? What are the cons of it, if there are any? And they've actually done some really good case studies on how do you effectively implement and integrate more effectively peers into the hospital setting. So you can just Google her and you can find all her papers. Very, very helpful if you're thinking about peer recovery in your hospital. She describes peers as culture brokers, and that's always resonated with me. That they have a way of connecting the sort of chaotic world that is the hospital with the sometimes chaotic world that people with substance use endure, and they are that sort of bridge. So they really are incredibly helpful, as you just heard Dr. Stuglik talk about. Can't say enough positive things about peers. William Ellis, how about from your perspective, challenges in the work that you do?
One of the biggest challenges is breaking the cycle in the emergency room, breaking the cycle of not this is not the cycle of person-centered. You know, what I see here in emergency rooms is a lack of education again. Not education on addiction, but education on stigma. I employ myself to learn what stigma really is, what's the root of stigma. So I took down some notes, I did some study, I took down some notes, and these notes are coming from a physician that worked in a hospital who became addicted to opiates during the COVID crisis. And her treatment when she was addicted was basically, she didn't get good treatment because of the stigma. So she started doing the studies. And so let's look at the root word, stigma. It's a Greek word that comes from what happened during the Greek times when someone was a prisoner or thief, or just say if they was an addict, then what they would do, they would brand them. They would take an iron, which means stigma, and they brand that person. So when that person came back in society, you seen that iron mark, that was a bad person. We fast forward to today's society. We don't brand them with irons, but we brand them with, I think Ms. Ogletree said it, we brand them with certain words. Our society is fit that they're bad people. So when they come through the emergency room, oh, here comes another bad person. And that right there gives them less care than the other person who came in with a disease, for diabetes, heart disease. So the stigma of addiction comes from the negative feeling that many in our society harbor for people struggling with opiate use disorders, and their beliefs that poor personal choices, moral failing, and defects of character are to blame for the disease. These feelings and beliefs mirror those in general public. Should a person who struggles with diabetes to control their blood sugar be denied the right for health care, to work, or to provide for their family, or to pursue life's purpose? So they did a recent study of exploring emergency physicians' attitudes towards patients with substance use disorder. And they found that the majority had lower regard for patients with substance use disorders than patients with other conditions. And that struck me. And another thing is, among the physicians participating in the survey, only 10% agreed that they would enjoy giving extra time to people who have substance use. And what happens in the ED, the challenge is being broken, because I had the opportunity to work with Dr. Stuglik, one of my favorites. And so when I go see a patient, I'm coming from a biopsychosocial profile. So I'm going there, I'm talking about, do you have family? You know, were you married? Do you have children? I'm making this person human again. I'm giving him his humanity. So when I go talk to Dr. Stuglik, who was working at ED, I say, hey, we got a guy over here. You know, this guy's got a wife out there. He's got children. He's been estranged from some of his family. He lost his job. And Dr. Stuglik said, well, what do you want to do with him? I said, I'm going to try to get this guy in treatment and get him, maybe if you get him dosed, get him some buprenorphine, get him doses, get him in treatment. So what happens in that is we made this person human again, because Dr. Stuglik is busy, so busy. But his part of the game is he can see the charts and he can see all the vitals and everything, which I don't know, and I see the human. So we put the two together and we got complete health care. But the challenge is getting this across to everybody, from the EMT to the nurse to the triage to the people upstairs. So, you know, that's the challenge. But they got to know the root of it. They got to know that it started from that we branded this person before he got in the door. And they were branded during the COVID, because I noticed in the ED, I worked through the whole COVID. I was about a month before I seen somebody with substance use come in. I was wondering, where are they? Did they stop? But what was happening, they was not picking them up. They was making a choice between the person who's overdosed or the person who's having a COVID crisis, and they took the COVID. And they got lost in that, and now we got a bigger spike. So the challenge is getting people educated on what stigma is, and how we combat that, how we make that person human. That's
amazing. So much to
awesome.
Talk about and unpack there. I want to highlight just a few things that you said. There was so much good content there. One is around this branding and devaluation of people with addiction, which we know happens today. The origin of that you so well stated around branding people, you know, physically burning the skin of enslaved people in Greek times. Obviously, we don't do that anymore in terms of physically branding people with a hot iron. But we really need to think outside the box of how do we brand people today? Because we still do it. We do it in the language we use, talking about people with addiction amongst our colleagues, clinical and otherwise, right? Even our family members and our friends, the way that we document things in the medical record around, you know, drug-seeking behavior and these types of things. So we still do that type of branding today, even if it's not, you know, physically branding the skin of someone. And I also want to highlight the piece that you said, William, about this idea that addiction is a moral failing. And one of the kind of origins around this that sociologists have found is that for many people in the sort of general population, they can go out on a weekend and they can drink, 1, 2, maybe more alcoholic beverages. They can get that euphoria of being drunk, for example, and then on Monday can go back to work and not drink again for a week or 2 weeks or 3 weeks. That's the majority of people. And so for those folks, it can often be very challenging to understand how the biological psychosocial disease of addiction plays out for other people, because to themselves, they say, well, I can stop whenever I want. Why can't this other person? And there's a huge disconnect in how we talk about this in our society. And there's this huge gap in appreciating that substance use disorder is a genetically driven, environmentally driven, biopsychosocial disease. It's very much like diabetes and heart failure and COPD and all of these other medical diseases that we see. We just don't think about it that way, and that certainly serves to drive the stigma. And the last thing that I'll say in sort of reflecting on what you said, William, this is more of just a disclaimer. It's so easy to throw our ER colleagues under the bus, and I know Dr. Stuglik will appreciate this, that oftentimes when we talk about addiction in the hospitals, the ER folks really, they get the brunt of all the negative stuff. But just to be fair, as a hospital medicine guy, we're bad at it too. Perioperative services, general surgeons, anesthesia, orthopods, everyone in the healthcare community kind of shares equal blame, not just our ER folks. So just wanted to share it. I didn't want Dr. Stuglik to get too discouraged here. So, Dr. Crozo, from your perspective, challenges from an ethical perspective.
Sure. So, in answering the question directly in terms of the example that was presented from my institution, frankly, I don't know of any subsequent barriers to the recommendation that came from me and my colleagues to the behavioral health service. I know that the result is that we at least have now 3 departments units who do practice universal screening. I think a standard response to this kind of question might be something along the lines of organizational or systemic barriers. So I'm happy to hear my co-panelists address where I went with this more or less, which is an elevation of the concern to a more general one, not about systems, but about persons. I would argue that the most significant challenge we face for addressing stigma is getting to the root cause psychologically, and that is an attention to the underlying presence of biases in our reasoning. And it's a careful walk from an ethical perspective, which I've also heard mentioned. And the reason being, because the standard response to those who exhibit what we think to be biased and thus potentially stigmatizing reasoning and beliefs is to morally judge the intention of those individuals as indicative of an ethically objectionable character, when the scientific literature seems clear that many of us employ biased reasoning with what we believe to be goodwill and good intent. And this is ethically significant, yet ignorant often to the live assumptions, speculation, and otherwise less than factual logic and mechanisms that are operating in the background. If I may make I think a helpful distinction conceptually, stigma can't be addressed. And the reason I say that is because stigma just answers the empirical part of the question. I'm not a scholar in this field, but it seems a matter of logic to me that when we identify stigma, what we're doing is collecting the empirical evidence as to a phenomena or a problem. However, the degree of fixedness or scientific generalizability, something like those experiences psychologically might be for people, we recognize the phenomena. So we might conduct empirical studies on what we deem to be behavior that is stigmatizing, but we don't address that directly. That's a descriptive fact. What we address is the psychology, the bias, the reasoning and the logic behind what ends up being picked up empirically as instances of stigma.
I love that. It's always wonderful to having a ethicist on the panel. I appreciate you being here.
Thanks for having me.
So, this kind of brings up the question of what can organizations do in building cultures in which, stigma can be very safely named and addressed, right? It's kind of just taking this head on. I sort of alluded to this earlier, Dreama, when you were talking about the Stigma Awareness Day, but what can organizations do to really take this on directly? And Dr. Stuglik, we'll start with you.
Well, I think it has to be purposeful. And I wasn't offended, like when you said we were talking about emergency physicians taking the brunt of this. And I will accept that William said I was one of his favorite. So I'll accept that and take that kudo. But I think as physicians and as healthcare providers, we have to set examples. We have to be examples. We have to act as leaders, and we have to make sure that the system that we're working within is a collaborative system. We have physicians, we have the peer recovery coaches, we have organizations, we have inpatient, outpatient, we have MAT. That it's a collaborative system, and that the cultural change that we create is purposeful. I mean, we can't just say, oh yeah, we're going to change the culture. It has to be something that is planned out, is thought through, is methodical, and is very purposeful. So overall, I think that's setting examples and making purposeful changes.
Absolutely. From one William to the next, William Ellis, how about from your perspective?
From my perspective, and first I'd like to apologize. I didn't want that to come across as all emergency physicians. Totally, it's everywhere. It's everywhere, and I totally agree with Mr. Crozo. I totally agree with him as far as I believe stigma will always be there. We might not even can change that culture to a certain degree. We might not be able to because it's so deep rooted in our society. But I think what we can do is basically we can address it in the healthcare field. And what would happen in that is that there are going to be those that we can save, and getting it in the healthcare field and making it part of some curriculums, and maybe looking at it as a two-part thing, because it borderlines, stigma borderlines discrimination. It borderlines. And if we can get it into the curriculums more and emphasize it, posterize it all throughout the healthcare system, and make it go viral, and we can bring it to attention more and more. I think that we can decrease the number of overdoses. We can decrease the number of the recidivism, the in and out. We can decrease a lot of that. But I think within the healthcare field, we have a lot that we can do. And because usually the healthcare field is probably the most vulnerable part that a human's going to be at, where he could be intervened with. Most people, you ain't going to catch them on the streets, and you're not going to get them while they're using. But when they come in this hospital, sometimes when you start talking family, you start talking life and career to them, and you bring a peer in there, they open up. And that's a point where we can get in, because we're humanizing them again and making them feel like they are valued. So I think that we can do a lot, and I think, but we have to make it a point of interest to put it in everywhere in the healthcare, not just emergency rooms, outpatient centers, in the dental office, in the chiropractor's office, everywhere, because we can reduce the volume of people that we're losing out here to this disease.
Thanks, William. And I agree with you. I think at minimum, stigma breeds discrimination, right? And directly leads to it. So, Dr. Crozo, how about for you?
Yeah, and let me just clarify briefly in response to William's interpretation of what I said. So when I say that we don't address stigma, I don't necessarily mean that, it's an unsolvable problem or it's intractable, socially speaking. You may have some fringe arguments here or there from an evolutionary perspective as to, our human tendency to typify or joint or classify being beneficial from an evolutionary perspective. But that's a different thing entirely. What I'm really saying is that just as a matter of logic, the problem is stigma, but we don't go after it in and of itself. We go after, the psychology that produces it. That being said, I think education is where things need to go here. Beyond taking on as individuals a responsibility of attending to our own, psychological mechanisms for biased or generalized thinking and developing ways we can increase our personal awareness of this phenomena. We need to educate our colleagues, we need to educate our learners, and we need to do so via formal education programming. There are many ways this could take form, small talks and opportunities for discussion provided to specific units and departments, incorporation of the topic into residency program lectures, residency program curriculums, didactics, anything. And we're already embedded in a lot of these groups as bioethicists, as accredited faculty to address things like informed consent, code status, advanced directives, right? Medical justification and moral agency. So why not biases? Why not stigma? Why not make that a standard topic for bioethicists at least, and maybe in collaboration with psychiatry to address more formally through education programming.
Yeah, I think one of the threads that's emerging in this conversation is education, right? I think education across the board for everybody. They should teach this in high schools, right? I mean, this should be something not just in the healthcare profession. We should be teaching this all around. Dreama, how about for you?
I think Dr. Strudwick kind of said it the best. Like, we have to be the change we want to see, and so it starts with us. And it's about not being afraid to politely and politically correctly, in whatever environment you're in at the hospital, to re-educate someone when you do hear them saying or going about things or not being, and educating them in a proper way, because that's the only way that things are going to change. But it ultimately starts with ourselves and educating ourselves. I know even when I first started at PIW, and even being in recovery myself, I still had this stigma around, methadone, and I educated myself on it. And I realized that if that's what somebody needs, then who am I to judge where their recovery is at? And so, taking from that own personal experience, like even being in recovery, we have our own stigmas against ourselves and against other substance use disorder people. And so it's about continuous education within ourselves as well, and then taking that education further. But you have to be the change that you want to see, and you have to not be afraid to have those hard conversations with people all the way up to the top, excuse me, with the physicians, with the psychiatrists, with the administrators, with the nurses, with people that, typically I would feel are in a higher up position than me. And who am I to tell them that they're doing something wrong? But sometimes it's just how you go about having those conversations, and that's what we need to do.
Absolutely. I want to turn to a question that came up in the Q&A box. And folks, we have about 15 minutes left or so please don't hesitate to enter your questions into the Q&A box, and we'll get to as many of them as we can. And the sort of general theme of this question is around messaging. And that so much of the messaging that we hear around substance use disorder really varies in its intensity, is probably a good word, depending on who the individual or the group is that is sharing that communication. I think the core of the question here is, how do you balance that, right? And I think it's important to highlight before we dive into this that that I would argue people with addiction are amongst some of the most marginalized people in our communities for many decades as a result of many different facets of policy and education and all the things we talked about earlier. And so as a result, there is a lot of mistrust, there is a lot of fear, there's a lot of anger. And so how do we navigate that when we're putting out communication related to SUD? How do we take into account all of these different viewpoints and really be sensitive in our roles as collaborators and conveners and care providers, and not agitate the situation, if you will. Who wants to take that on first? All right, Dreama, actually Dreama, sorry, you just spoke. William, and then William Ellis, and then we'll go to Dreama. You want Dreama to go first? Okay, Dreama, you go first.
So I think it's about knowing your audience. So Nancy Reagan back in, when Ronald Reagan was president, started the Just Say No. And even though that's obviously not the most effective slogan, it did open up a conversation. And obviously the conversation that I would have in regards to substance use disorder and alcohol and drugs with somebody who's in elementary school or middle school and high school, and then, as somebody gets old, is not the same conversation that I would have with somebody in their 30s, 40s, and 50s. And so I think that it's important to know who you're talking to and know your audience, and getting to know your patients and the climate that you're in, or getting to know, who you're talking to, what I may say to a psychiatrist, or what I may say to a patient that I've been working with for 6 months. Those may be two totally different conversations. So I think it's just really important to know your audience and go from there. The important thing is getting the message out there. And if you're unsure, then asking somebody and humbling yourself to ask somebody who knows more than you, how do I have this conversation?
Thanks, Dreama. William, is your mic working?
Yes, it is. When I looked at the question, the first thing in my mind was like, oh no, we don't message through social media about this disease. It is I think that's even stigma within itself. I don't use those social media. First, I think the person has rights, whether they're written or not, they have rights. The person's anonymity belongs to them. And most of all is the ethics, comes back to ethics, If I care about the person, why would I put it on social media? If I care about this disease, why would I make it a social media issue? It's not a social media issue. This is a universal issue. So the platform that I believe that should be used is more of an educational platform. Not social media can destroy. It can destroy. And my ethical part of me would not want to do that. Would not want to destroy another human by something that was misquoted or was quoted right on social media. So I've discouraged using social media for anything when it comes down to addressing substance use disorders. And like I say, when we're talking about a human, when somebody's on fentanyl, lay there, overdoses, we're talking about a human down there. We're not talking about a trash can or some old bicycle. We're talking about a real human life there. And I just discourage it, and I don't like, I discourage it all the way. So I don't use social media. I don't recommend using social media, not even to even talk about on a professional level. I think there's so many other ways that could be done. So that's my take on it. We have a thing, and I'm part of the Fellowship of Recovery, and that OSHA has described that the 12 and 12 is one of the most effective ways for a person to become in continuous sobriety. And one of the reasons it works is because it's not promotional. And people have their rights to their anonymity. And, they don't use press and radio to, and it's worked for since 1939. So go figure,
Yeah,
So,
absolutely. I wish more people would adopt your view of social media, right? As an unfortunate frequent consumer of social media, I can tell you most people do not. But I appreciate that perspective for sure. We only have a handful of minutes here, and I want to get to this next question that came in from a participant, which I am not going to be able to answer at all since I'm in Colorado, but it's about keeping it local. What are opportunities that currently exist or that may be coming down the pipe in the DC area that are programs that offer non-stigmatizing treatment, initiatives that work on stigma? What's happening in the DC area to work on this? Let's see, Dr. Stuglik, do you want to start us off?
Yeah, I mean, I think things are growing in this area. I think the peer recovery coaches. I know, for instance, in our hospital, we're hiring more peer recovery coaches. We want to make sure that it's covered 24/7 in our emergency department and in our inpatient service, because those, you're able to get people where they are and where they live. And a lot of times, as has been said previously, people come to the hospital, enter into the healthcare system for different reasons, but ultimately the primary reason is substance abuse, whether it's HIV and sharing needles, whether it's trauma, whether it's crime. A lot of things are associated with substance abuse. And so just being able to make this more broad spread, educating physicians about their place in recognizing patients and trying to get them to care. Physicians recognize their place in medical assisted treatment. I think things are growing, things are getting better. People are having a better understanding of what it is, and as William, so eloquently spoke about the value of humanity in each human life. So I think we're heading in that direction.
Absolutely. Dr. Crozo, are there initiatives happening locally beyond the awesome work that you're doing to bring more of a ethical approach into treating addiction in hospitals?
Well, I mean, again, I must be fully transparent here. Stigma is not my area of scholarship. And I think that, if it were, I would have my hand on the pulse a little bit more. What I can comment on is what the philosophical response at a clinical bioethics level has been to some degree. And that has also been mentioned in today's panel, which I was happy to hear, which is addressing language and addressing language in the literature. So as a philosopher, my main form of influence is through the written word and through publication. So we argue theoretically and logically for why language creates problems. And this has been an issue in moral philosophy for a long time. So if you don't mind me kind of breaking this down for a second, the complication comes in when we start using what sometimes are referred to as thick terms. So terms that we might consider value-laden. This is also an issue in scientific process, right? When we're discussing the relevance of empirical work versus moral work, or epistemic values versus moral values, words that carry some sort of implication. So for instance, I could give you a purely descriptive, factual cause and effect chain, one fact leading to the other, leading to the other, leading to the other, and resulting in the death of an individual as caused by another individual. Whether I call that chain of events a killing or whether I call it murder bears a sort of a bit of a hidden, if you will, a smuggled moral adjudication of the act. But in fact, it's nothing but a descriptive occurrence. It's just fact after fact after fact. So the more we make sure that our language and concepts adhere to what is descriptively being picked up, the facts of the matter, and have less an implication as to the moral quality unintentionally of what is being described as facts of the matter, then the more we'll avoid these thick terms that carry these implications, right? So kill versus murder is one. I tell you that chain of events was killing. You might ask me whether it was an accident or not. If I tell you that chain of events was a murder, you're not going to ask me whether it was an accident or not. You're going to automatically assume some moral culpability. If we assume moral culpability in patients we don't know or understand, in terms of their disposition or their potential for high risk in SUD, that in and of itself is the moral offense, right? To some degree, it's an inappropriate moral judgment because you're employing stuff you shouldn't be employing, or you're not being careful with your terminology. If kill and murder is a little bit too high up, another example might be when we talk about patients as being non-compliant with their medication as opposed to inconsistent with their medication. I talk about a patient being inconsistent, I'm doing nothing but describing a set of facts, a descriptive account. This medication is not being taken when it was prescribed to be taken. I talk about a patient who is non-compliant, and I'm making an adjudication over the character of this patient as presenting a personal problem as the cause of why that medication isn't being taken. So to answer the question, I think language is something I see being addressed a lot in the literature, and language is huge here.